Hello friends, welcome to Health, Music and Fitness channel. Today we'll be discussing about atrial arrhythmias, and in this video we'll be talking about atrial fibrillation, atrial flutter, PAC which is premature atrial contractions, and MAT which is multifocal atrial tachycardia. You're watching Health, Music and Fitness channel, and if you like our videos, please do subscribe and click the like button and share the video with your friends and hit the bell icon. So let's continue. So in atrial fibrillation, the atrium is beating at the rate of 400 to 600 beats per minute, and the impulse is arising well within the atrium. And not all the impulses they can travel across the AV node to the ventricles. Otherwise, the ventricles won't be able to pump effectively. It will be a sort of ventricular fibrillation, and the patient will die. So what the AV node does is it filters out some of the impulses which are coming from the atrium to the ventricles, and the atrium will be beating at 400 to 600 beats per minute, whereas the ventricular rate will be at around 100 to 200 beats per minute. The heart rate is irregular. So if you keep your stethoscope on the precordium and you feel the pulse also, you will see the heart is beating at its own rate and the pulse is beating at its own rate, and the heart rate will be more than the pulse rate. So that is called pulse deficit. This is in atrial fibrillation. The pulse deficit of more than 10 is significant. So first, in this ECG, you see look at the calibration. The calibration is normal, is 10 small squares in height, and the plateau is horizontal. So the electrical voltage is calibrated normally, and if this calibration is not given to you, you may not comment on this ECG. So the calibration is normal. Then you look at the Qrs and T waves. This is the second step, and in this you will see you can't appreciate the P waves, and because the atrial rate is around 400 to 600 beats per minute, so atrium produces very little electrical impulses in one impulse, and it will give a fibrillatory type of pattern on this isoelectric line, and this is fibrillation. This is atrial fibrillation, and the atrium are beating haphazardly, and so not enough cardiac output is created and not enough blood is pumped into the ventricles. So each time the ventricles contract, the peripheral pulse is not formed. Whenever the cardiac output is good, the stroke volume is good, and enough blood is pumped into the peripheral artery, the pulse is generated. In other words, the ventricles will be beating at a faster rate and the pulse will be at a slower rate. So if you keep your stethoscope over the precordium and listen to the heartbeat, and simultaneously you keep your finger on the radial pulse, the cardiac pulsations over the precordium will be heard more number of times and compared to the peripheral artery pulsations. And this is the main feature of atrial fibrillation, and this is called pulse deficit, and a pulse deficit of more than 10 is significant. Now we'll discuss causes of atrial fibrillation. For this I have made a small mnemonic, his debts, like as if somebody has borrowed money from somebody and he is in debt. HISDEBTS, his debts. So this is a mnemonic for causes of arrhythmias. So we'll go to the first one, H for hypoxia. Any condition causing low oxygen levels can precipitate atrial fibrillation, like bad COPD causing hypercarbia, hypoxia, and decreasing the oxygen concentration of the blood which is going to the coronaries. Acute LVF, the lungs are filled with fluid and they can't produce enough oxygen and liberate enough of carbon dioxide. Then carbon monoxide poisoning and things like that, anything causing hypoxia. Then ischemia, CAD, coronary artery disease, different types of coronary artery diseases, acute myocardial infarction, and like in acute MI there can be atrial fibrillation also. And at this point you should remember, whenever there is atrial fibrillation you should look for inferior wall MI, and whenever there is inferior wall MI you should look for right ventricular infarction, posterior wall infarction, and atrial fibrillation. And sometimes the patient will come to you with chest pain and you do the TROP-T, it is positive, and you look at the ECG, it is normal looking. In that case, you should look at the ECG again, look at the P waves, look at any elevation of the distal descending limb of the P wave in certain leads, and which might signify atrial MI. So this is one of the most common diagnoses which is missed, and the patient is TROP-T positive and the ECG is normal looking. But if you look at the P waves, you will see signs of atrial MI. Then I for infections. Infections like subacute bacterial endocarditis, which involves infection of the valves and vegetations grow on the valves, and this will occur usually in a patient who has mitral stenosis, rheumatic heart disease, pre-existing rheumatic heart disease, and the mitral valves are destroyed and they get infected secondarily. And sometimes you will also see infective endocarditis in the patient who is abusing drugs and taking intravenous drugs. In that case, they will have vegetations usually on the tricuspid valve, because the blood from the veins, it will go into the inferior vein, because the blood from the veins will go into the right heart. And whenever there is mitral stenosis, it will cause back pressure change in the left atrium, and the left atrium will dilate, and that will trigger atrial fibrillation. Then comes stretch. S for stretch. Any condition causing dilatation of any of the chambers of the heart can precipitate atrial fibrillation. For example, dilated cardiomyopathy, mitral regurgitation, acute LVF or chronic LVF, right ventricular dilatation, and pulmonary embolism. Now you might wonder how pulmonary embolism can precipitate atrial fibrillation. You imagine that there is a big clot in the pulmonary artery and causing back pressure changes on the right ventricle is dilating, and it causes pressure changes, right atrium is dilating, and atrial fibrillation is ensuing from the right atrium. So like that. Then D for drugs. Many of the drugs, they will cause tachycardia, bradycardia, and can precipitate atrial fibrillation, like atropine, adrenaline. Most of the cardiac drugs, they can precipitate different various arrhythmias. Xanthines, methylxanthines, theophylline, ethophyllene, and things like that, they can precipitate arrhythmias, which include atrial fibrillation also. Then E for electrolytes. And at your level, you can remember just 3 electrolytes which are cardioactive: potassium, calcium, and magnesium. So hyperkalemia, hypercalcemia, hypermagnesemia. So these conditions can also cause atrial fibrillation. Bradycardia, things causing bradycardia, like things like hypothyroidism, sick sinus syndrome, complete heart block, they can precipitate bradyarrhythmias, and which can further ensue atrial fibrillation. Then T for tachycardia, hyperthyroidism, hyperthermia. Many a times you will see your patient is not responding to certain drug which you are giving for tachycardia, but then you check the temperature, he is having hyperthermia. You give a tablet of paracetamol and the tachycardia subsides. Then S for sympathetic system stimulation. Anything causing stimulation of the sympathetic nervous system, like coffee, xanthines, atropine-like compounds, and nebulizations which we give to COPD patients with the beta stimulants, they can cause sympathetic nervous system stimulation. And then anxiety, watching too much of TV and listening to news and bad news, and they all can stimulate your brain and cause tachycardia and can cause atrial fibrillation. The rest of the atrial arrhythmias we'll discuss in the next video. So friends, this was all about atrial fibrillation from ECG point of view. If you like our videos, please subscribe to our channel, hit the like button, and comment and share the video with your friends. Also hit the bell so that you can be notified of all the videos which we upload in future. Thank you.